So, thank you very much. It's a pleasure to be here. The question that Dan asked me was, does pediatric postoperative pain require opioids? And the answer is yes. Thank you very much. Okay, I guess I've got a few more minutes. I should say something else. This has been an interesting day. Sue Ellen preempted most of what I could have said this morning very nicely. Bill Schmidt's going to put us all out of work, I'm pleased to hear, with this new compound for mucosis. I mentioned I did have a few worries about that. This compound that's derived from caterpillars, because in pediatric practice that might interfere with metamorphosis into adults. So it's a problem. One of my colleagues said, with respect to anesthesia, but other things, that it's a serious mistake to treat children like small adults. However, if you treat adults like big children, you're probably going to be just fine. That's a philosophy we like to take. I'm not sure quite why I'm in this section on measurement, because this talk is going to be pretty much data-free. Hopefully not like Donald Trump is data-free, but I'm going to just express some opinions and raise some points that may or may not generate discussion. Opioids are actually pretty amazing compounds. You can put them in almost any orifice or access to the body, which makes them extremely flexible. In acute pain in kids, we don't tend to use sustained release versions, and we don't tend to use intramuscular versions because kids will tell you that they don't have pain if you're going to hurt them by giving the pain medication. However, that subcutaneous intermittent injection through a butterfly needle is an incredibly cheap and practical approach that can be a poor man's infusion in areas that are resource limited or where there's no equipment or personnel to provide continuous infusion. One of my main interests is, in fact, in pain service in resource limited areas, countries or settings where there just isn't the money, the training, or the people to provide a lot of the techniques that we've been hearing about today. Most of this research and these approaches are coming out of rich countries with lots of ability to implement different techniques. Gui from India said years ago that the problem is the drug not reaching the patient, not reaching the site of action. A friend of mine from WHO gave me this slide. The drug problem that we deal with in many parts of the world is that you can't get the drugs. So putting it in that context, we're talking about really very cheap and easily manageable drugs when we're talking about opioid use. However, we recognize that there are problems with opioids and that morphine isn't the cure for everything, in spite of the fact that this morphine-containing compound was advertised as magical. And so we can look at other techniques. I was intrigued by Dr. Darnell's presentation this morning. My friend and colleague Jill Shorney and her colleagues have just published this review in Pain very recently, looking at the psychological techniques that have been studied for pediatric pain. One of the problems, of course, is that there isn't as much data for pediatric applications for most of these things as there is for adults. In general, there was evidence for some value of psychological techniques in perioperative pain management, particularly perhaps the distraction imagery group of approaches. And so there's clearly more work and exciting work to be done there. Paracetamol is used all over the world for a long time, generally safe, generally effective for mild and moderate pain, as you well know. And all by itself isn't going to handle the big things. Non-steroidal anti-inflammatory anti-inflammatory drugs come into the same category. One of the problems is the prevalent belief among surgeons that these can cause increased bleeding or impair bone fusion. Training surgeons is always a challenge, and whether or not these are true, they are impediments to their use in some types of procedures. Neuropathic issues are a problem, and we've heard excellent discussion today about the use of gabapentinoids, ketamine, lidocaine, and so forth to try and prevent persistent nerve problems. I defy any surgeon to make an incision without injuring nerves in the process. And so I don't think we can avoid the fact that there is peripheral nerve injury whenever there is surgery. They may be small nerves, but they still count. And we have a long history in pediatric anesthesia of regional techniques. But again, not always practical or possible. Wound infiltration clearly could be used in essentially all types of surgery by the surgeon. Newer compounds coming along will be exciting, give us exciting opportunities, but as yet they aren't available. As a friend of mine also, another friend of mine once said that adults are there to practice on until you get good enough to do it in children. That means that every time you're talking about new preparations, new compounds, new techniques, it's going to be years before we have easy access to them in pediatric care. Peripheral nerve blocks can be done by the surgeon or the anesthetist. Caudal blocks are not in the repertoire necessarily of every anesthetist or anesthetic technician or nurse in different parts of the world, but they're fairly straightforward and easy to do. Epidurals, in particular, in small children, really are within the repertoire of the pediatric specialist anesthetist, I would say, more than a generalist. And even more so, plexus and major nerve blocks in small children require some specialty training. So you really can't block everything all of the time. And you may or may not disagree, but there are some procedures that I just can't imagine how we can manage without using opioids at the present time. There are things you just can't block, or you can't use non-steroidals, you can't use other medications effectively, and there's just really no choice. Spinal fusion, we do a lot of VP shunts, major procedures, multiple trauma, even adenoidectomy, tonsillectomy, cleft palate. You can sometimes do local blocks, but those cause other complications and problems. I would just say that in chronic pain practice in pediatrics, opioids are used very infrequently, certainly in our practice, and I think most people's. And in spite of the current public and media concern about opioids, I really don't see that as an issue. We only use them if the patient can prove that the function is better, not just the sensation. So I will conclude this very short presentation and give lots of time for other people by reminding you of Sydenham's comment from several centuries ago that of all the remedies it has pleased God to give to man to relieve his suffering, none is so universal and efficacious as opium. Thank you. Thank you very much. And I will also remind you and invite you to the International Symposium on Pediatric Pain, the Pain in Childhood SIG Congress in Kuala Lumpur next year. Thank you very much.